and it was kind of like blocking it, but I was able to
Okay, it's live streaming now, so you can pull up your slides and should be good.
okay. Hello, everyone. Just give me 1 second. Can everyone see my screen? Hello, everyone. I am Jada Reeves. I am one of the Arts Review FNP instructors, and I will be going over the HENT webinar with you today. Welcome, and if you have any questions, please feel free to just drop the questions in the chat, and we have someone that will manage your questions, and just feel free to jump in and ask anything at any time, okay? So today we're going to be talking about the head, ear, eyes, nose, and throat, and common conditions. So first thing we want to just take a quick look at the eye, the external eye and the internal eye. Is always important to know your anatomy, and when you're doing your assessment and when you're doing your documentation, it's very important to know the anatomy of the eye, internal, and then when you're looking in the eye um, with your ophthalmoscope, it's always good to know what veins you're looking at in the retina, the optic nerve, and the macula, and those are very important for charting. And another way to do a good thorough assessment when a patient is coming in is taking a thorough history, and we like to use an acronym called OCART, and that is onset, like when they have a chief complaint, like when did it start, where does it hurt, how long does it last, can you describe the pain, those types of um, questions your patient can give you thorough answers in case they don't know, exactly what to tell you or describe what's happening. When you do this OCART acronym, you can get an accurate description of what is going on with them. So if all else fails and you're in a situation, just think of the acronym or write it down on a piece of paper and then just go down the acronym. So when did it start? Where does it hurt? How long does it last? Can you describe the pain? Anything makes it worse? Anything makes it better? Does it go radiate up and down or anywhere else? How long does it last? And those are very important. So general medical problems that affect the eye is diabetes, people with heart disease, high blood pressure, thyroid inflammatory diseases like sarcoidosis, especially allergies. You'll get a lot of allergy complaints in certain seasons of the year. And oftentimes, people allergies, they may think it presents as an infection, and oftentimes it can be controlled or symptoms can go away when you're using your allergy medication. So you always want to make sure that you do a thorough assessment and not over prescribe or misprescribe antibiotics when it's not needed. When for a normal regular exam in a doctor's office, we will do an eye test. We use the Snelling chart, and that is one of the letters where it measures the central distance of the area of the patient's vision. Normal vision is 20/20, we say. So we have a patient stand 20 feet away so they can we can see like what is expected. Now, what is 20/40 vision? What does that mean? That means like if a patient is standing 20 feet away and sees what a normal person would see at 40 feet away, then their vision is worse. And a 20/200, that is considered like legally blind. So someone would probably not be able to drive if the vision is like 20/200. And we use a vision test like the peripheral vision. So how do we do that test? That would be when the visual fields of confrontation exam, where we look at any of the scomatas or blind spots. And for color blindness, you can check that with this type of test. And do you know what this test is normally called? Does anyone know? It's the Ishihara chart, the Ishihar, Ishihara chart. Okay, we'll move on. This is a very important. We have red flags. You need to know when to refer out. So if someone is complaining of visual changes or visual loss that's sudden or onset, someone's complaining of eye pain, photophobia, if they have a headache that's accompanied by vision loss or any recent trauma, decreased visual acuity, or they have pupil irregularity or sluggish pupil or reaction to light, those are all red flags. You want to make sure that you refer them out to a specialist if you identify any of these type of conditions when you're doing their exam. And on exam, if there's signs of concerns for any decreased visual acuity, you want to get a thorough history from the patient before you do a thorough history, and you want to do a thorough assessment when you're doing your referrals. And when you document, we document PERLA, and that stands for pupils equal, round, reactive to light, and accommodation. So let's take a quick quiz. You just drop an answer in the chat. What is the most common cause of vision loss in older population? And if you said macular degeneration, that is correct. So remember, this is slow loss of central vision. And what we would do, what would we do for this patient is refer them to an ophthalmologist, and they will take over their care and manage their macular degeneration. Our job is to make sure that our patients are up to date on their eye exams. So we always ask those important questions if they want to, when was the last time they had their eye examined? And so we would refer them out if we were to detect macular degeneration. Let's look at some common eye conditions. We'll just review a few that we would see in primary care. So one that is very common and we see quite often is conjunctivitis. That is a bacterial infection that's in the eye. A lot of times we call it pink eye. My son was just diagnosed with it 2 weeks ago. He started off actually with just a runny eye, and it looked like kind of bright red, irritated, and we thought it was allergy related. And then like a week later, it started crusting over. So when you start seeing that yellow crust or sticky in the morning, um, the crusted eyelids are shut, we want to get them treated on a bacterial antibiotic. A lot of times they may complain of itching or irritability in the eye, and they often scratch. So we want to do some patient education as well and let them know proper hand washing is very good. Try to avoid touching your eye. Um, Teach them to clean their eye when they're wiping it out, to wipe from inner to outer, and don't go back over the same spot using the same spot of the towel. Um, the best treatment is antibiotic ointment or drops, and also patient education, because we just don't want to reinfect the eye or get the other eye infected. So you, in addition to good hand washing, we want them also clean their pillowcase, change their pillowcases. If they wear contacts, we want them to switch it out or avoid wearing their contacts so the eye is the infection is cleared up, and possibly replace the contact they were wearing with a new pair once the eye is healed and the infection is gone. It is also contagious, so you want to be careful not to touch your eye and then, I don't know, touch someone else's face or touch their eye, because we don't want to spread it. So it's very important to know that. And there's also viral conjunctivitis, and sometimes it's hard to differentiate between bacterial and viral. But the best way I would look at it is how long they've been dealing with it. Like, for example, when I said my son started off earlier 2 weeks ago with the red runny eye, and he has bad allergies. But after watching it for a week, and then it's getting worse, and then the drain is just starting from turning from clear to more creamy, purulent, and crusty in the morning. Then I knew, like, you need to go be seen so you can get an antibiotic. But with viral conjunctivitis, sometimes it's related to a cough, a runny nose. The discharge is very clear. It's not thick and or yellow or discolored. A lot of times, just like they have watery eyes, and you get this quite a bit. Some patients want you to treat them for pink eye, because sometimes the eye is red, but it's irritated from the allergies, and it's just not good to prescribe a an antibiotic for a viral conjunctivitis, because one is not going to work. It's not going to kill any bacteria because it's all viral and it has to run its course. So you want to teach or educate your patient about over-the-counter medications that could just help with the symptoms. You can get an eye drop, or you can take some allergy medicine. And also, if they have a runny, stuffy nose, they can take Flonase or take something to help with the symptoms. Viral and bacterial usually start with one eye also, and if it's allergies, it's usually both eyes. So that's another way to tell too, if it's another way to tell between bacterial and viral. So if it starts in one eye and it stays in one eye, it's probably could be pink eye. But if it's both eyes, more likely it's maybe allergic conjunctivitis. And a lot of people complain of the same thing. It's itchy, it's irritating, it's bright red. Another other things that you can use other than medications is cold compresses. That kind of helps with the irritation and the itching, and just make sure that they keep an eye, that they don't continue to touch their eyes with their fingers, because it could turn into something bacterial if their hands are not clean, and they could put something in their eye. Okay, we'll move on. So here are some eyelid concerns, which is another common eye complaint, is hordeolum or a calzone. We call it like the little nodule that develops on the lower part of the eyelid, and it's external. A lot of times it's more cosmetic looking, where it's bothersome to the patient. And it could be internal or external. It's swollen, it's tender, it's very red. It's kind of like a nodule. The hordelum, we call it like a sty, and it can stay for a little while on the eye. Then the calzion is a gradual onset. It's like the upper or lower lid. It's painless. It forms. It's like a dome-shaped nodule. A lot of patients may complain like it affects their vision, like because they can see it, and it's actually more serious. So it's good to know the difference. So with a hordelum or a sty, it's abrupt. It comes within 1 day or overnight. It usually improves within 1 or 2 weeks. Just have to encourage your patient to just not touch it or bother it. Like it will eventually go away. Antibiotic therapy is not indicated. Sometimes, like I said, if it's tender or swollen, you can get like a warm paper towel, like a paper towel with warm water to just sit on it a little bit to just kind of help with some comfort. Um, Sometimes it may help it shrink or go down or go away a little faster, but just encourage your patients not to squeeze it. If there's a concern for it spreading or becoming like a cellulitis, then we definitely want them to get referred and or start on the antibiotic treatment. And if it's anything like complication of cellulitis, it can progress to the chalazine, which is more serious. Now, chalazine is inflammation in the mobium gland, which is your sweat gland in the eye. And that's why it's also important. Just know your anatomy. And when you're doing your documentation and thoroughly documenting, it's a gradual onset, like within days to weeks. Typically, it improves over several months. So they can have this for a while. It's more common to show up on the upper eyelid, which patients like complain because it's just like this thing you can see in their vision. It doesn't stop them from being able to see. It's just a visual disturbance. It can resolve on its own with a warm compress. Refer if it's not improving. After you watched it for a couple months, it's not improving. You should refer them. Or they may need a steroid injection. If that's out of your scope of practice, you definitely want to refer them. And sometimes it may require surgical removal. The complications is that the eyelash, when it's on top of the eyelid, the eyelashes are lost. The eyelid is like a nodule. You can see it. It's a visual change or disturbance, and it can get larger. So these are the things we want to just keep an eye on and kind of reassure our patient, that we're keeping an eye on it and monitoring it very closely. Okay. Keratitis. That's inflammation or irritation of the cornea. So what you would see with keratitis is eye redness or eye pain, photophobia. They have blurred vision, um, excess tears or discharge from the eye. Sometimes they have difficulty opening the eyelid due to pain or irritation. And it sometimes may feel like something's in their eye. So the patient feels themselves blinking all the time because it feels like something's in their eye. This is normally caused by infections, even dry eyes, people who have abnormalities of their eyelids, even injury to the eye. It could be related to a disease or if they're wearing contacts for too long. So treatment depends on the cause and the complications, if it's any scarring or a corneal ulcer, or if there's vision loss, then that requires prompt medical attention because we don't want that to happen. We don't want it to get to that stage. And what's most important is that you do not prescribe steroid drops. Some infections can get worse when you use steroid drops. And if it's an emergent referral, we want to refer them to an ophthalmologist to diagnose and treat. And they can use that fluorescein staining where they'll put something on the eye and they'll be able to tell to see exactly if it's a tear or what is exactly on the sclera, and they will be able to properly diagnose if it's a corneal abrasion. And corneal abrasions are very serious, so we want to know when to refer out. Okay, all of our patients who wear contact lenses, our job is to properly educate them, um, let them know when to discontinue contact lens, when to discontinue wearing their contact lenses, and if whether or not it's a contact lens issue or if it's actual keratitis. So prevention is key. And a lot of times people who do wear contact lenses for a long time, you can get some type of keratitis or corneal abrasion if you forget and you rub your eye and you're scratching your eye. So we want to just avoid eye injuries altogether. And so it's also very important and I know when they go get contacts, we don't want to assume that our patients just know everything. And it's just always good to re-educate, because when you do go to the eye doctor, they do teach you about your contacts, properly cleaning them every day and how to clean them. But we just want to reiterate it when they're with us. It's an opportunity to teach, so our patients something, so we just go over real quickly. And also it's important to remind them not to sleep in their contacts. Now, what if a patient tells you they had something tingling on their face before they had a red or crusty rash that shows up along their face or along the dermatome? Would you think that they had, what would you think if someone came to you and said, I have tingling, a crusty red rash? Would you think zosters or shingles? And remember, this is an emergency that you will want to refer out. If someone had herpes keratitis, it's an infection that's caused of the cornea by HSV. I don't know if you did the STI webinar, but we talked about HSV, herpes simplex virus. It typically heals without damage, but in severe cases, it can lead to scarring and blindness. It's a potential sight-threatening condition, and is defined as herpes zosters involvement with the ophthalmic division in the fifth cranial nerve. So when we do our cranial nerve assessments, we check the cranial nerves in the face. So that is one assessment you would consider doing, but it is an emergent referral to ophthalmologist. Okay, let's talk about glaucoma. Glaucoma is a form of damage to the eye's optic nerve. The optic nerve transmit information from the eye to the brain. If it's left untreated, it gets worse and can lead to vision loss and even blindness. It's also the second leading cause of blindness in the world, most common in older adults, but you can develop glaucoma at any age. And it develops slowly over time. So the symptoms are often not recognized. So you want to make sure your patient is getting a routine eye exam every year. And then there are two main types of glaucoma. You have primary open angle versus closed angle. So open angle glaucoma, a patient may complain of cloudy vision, a difficulty seeing with light, conditions that change their peripheral vision loss. That's what we do the peripheral vision test. And then also central vision loss in severe cases. An angle closure or a closed angle glaucoma, that means the iris, it blocks the normal drainage of the fluid in the eye. So most people don't have symptoms, but they can have an acute attack, so sudden. And they'll have symptoms that include like headache, eye pain. They see halos around lights. Sometimes they have dilated pupils or vision loss, red eyes, even nausea and vomiting. So that is very high pressure, which means that's a medical emergency. You want to get them seen as soon as possible. So diagnosis on a routine exam, you want to examine the damage to the nerve, to the optic nerve. About half of patients with glaucoma, they have eye pressure in the normal range. And people with high pressure, they often develop glaucoma. So measuring eye pressure is part of the eye routine care, but that's at your eye doctor's. When you go to your eye doctor and they check that pressure, that's what they're checking for. In clinic, we test for their peripheral vision and their visual fields. So treatment, the goal is to slow it down or actually stop the progression of vision loss. We want to slow down or stop like the damage, slow down the progression of vision loss, but the damage to the optic nerve cannot be reversed. So the goal is to catch these things early to prevent severe damage. And that starts with early detection means just getting your eye appointments, going to get your eyes checked. That's why it's important. Prevention is actually going to get your checkups. But you start treatment to delay progression once it's identified or diagnosed, rather. All treatments lower eye pressure. Sometimes there's laser, medication, and surgery that can be done, but this all is managed by ophthalmologists. Our job is to make sure that they're getting their routine checks. When they come in for visits, that's why we ask, when the last time you've been to the eye doctor, when the last time you've been to the dentist, because all these things can lead to other problems that could be avoided. So what is this that's going on in this patient's eye? You can take a good look at it. What if you find, what if your patient comes in and the eye looks like this is red, and they might be complaining of having a cough, or maybe even lifted something heavy, like say if they burst a blood vessel in their eye. So what would you call this? This would be considered a subconjunctival hemorrhage. And even though it looks pretty bad, it looks kind of scary. I don't know if you've ever popped a blood vessel in your eye, or if you ever seen someone who had a blood vessel burst in their eye. It even happens to someone get hit in the eye too hard and you see this redness. But it's actually not serious. It does go away on its own. It may take some time as it heals. And it's pretty common. You can see this pretty commonly in infants or young children, especially if they just now getting over a gastroenteritis or some type of respiratory infection. Sometimes people who have chronic coughing, they can burst blood vessels in their eyes. But like, let's say if the mother of an infant said that they had tearing or some eyelash matting when they wake up from their sleep, and say, so what would be going on with this patient if a mother was saying this? Then that could be a congenital lacrimal duct that's obstructed in the child's eye or the baby's eye. Or we call it like a blocked tear duct. In the vast majority of cases, this also resolves on its own. It's like if a baby that's 6 months old or older, we can put warm compresses, but you also make sure you want to check the temperature of any type of compress, anything that you're warming up to put on a baby's eye, just like how you test the milk before you give it to them. That's the same thing with smaller children. They're not really able to react or have a reflex to snatch back if something's too hot, and their skins are so delicate. So you just want to be careful if you're using a warm compress and putting it on a baby's eye. So you teach that to the parent to make sure they test it on the back of their hand to make sure it's not too warm. But if they do have some type of blocked duct, a warm compress could help kind of loosen that secretions up in that duct and kind of loosen it up to start draining again. So just want to know that education is key. Okay, so what could this be? You see, it's filling up in the back of the eye. If a patient came in and had sudden painless loss of vision, and they may also complain of a sudden increase of floaters, like in a matter of minutes. And a floater is like where you're looking at something and you can see like a black dot or a spot, and it's moving wherever you move. Every time they move their eye in their vision, they see it. So that would be considered a floater, or like it's kind of a shadow. Um, so what would you suspect? So what's going on here is a retinal tear or retinal detachment, if you guess that. What do you need to do? That is a very urgent referral to the ophthalmologist, and they need to be seen like the same day or within 24 hours. It's very serious. I I had a friend who had type 1 diabetes all their life, and one day they woke up and they went to pick up a newspaper. Well, they woke up and they looked down on the floor. They thought they saw a large black bug, and they said they went to reach for the newspaper to grab it to kill the bug. And when they went to reach for the newspaper, they seen the same spot on the newspaper and realized, oh God, what's going on with my eye? And when they called, I said, it sounds like you got a floater. I don't know what's going on. And it turned out to be a medical emergency um, for my friend. And within a few months, he was almost legally blind because of these floaters and complications of his diabetes. So it's always important to make sure that they follow up and get care. A lot of times you don't have to force patients to follow up on a medical condition when it's their eyesight, because they take that very serious. But we want to make sure they're seen within 24 hours. Okay, let's move on. So here are some key takeaways. Um, Recognize the red flags, know when to refer, and always do patient education for prevention, prevention, prevention. That is the most important thing we can do for our patients. And let's move on to the ears. So just here's a little anatomical structure of the ears. So it's always important to know your anatomy. Okay, so let's start with the Ryan test. What sort of hearing loss does the Ryan test for? That would be conductive. So in a normal Ryan test, AC greater than BC. But what does that mean? So if that means that a patient who hears noise from a tuning fork for a long amount of time, when it is held right off the ear in the air, that's called AC. And then when it's placed on the mastoid process on the bone, that is called BC, bone conduction. So under the ear would be heard less time than the sound through the air, if that makes sense. So when we do that tuning fork, and I know you had that in clinical, where you put it here and then you move it and move it to air, and the air conduction should be stronger or louder. So let's say if bone conduction is greater than the air conduction, then we know we have a conduction problem. Something you can see are things like, could be otitis media, or something that could be going on, cholestomia. So when we do these type of tests, we do a thorough documentation and do follow-up or referral. And then we also would do the Weber test. And with the Weber test, you can test for conductive or sensorineural hearing loss. So again, conductive is something that we can see, and sensorineural is something we cannot see. something like Meniere's disease. Um, can't see that, but we can use a Weber test, and we take the tuning fork, we strike it, and we put it somewhere in the midline of the patient's nose or the top of their head, and we ask the patient, can they hear it, which ear can they hear it better in? So they can hear equally in both, or hear more in the left, or hear more in the right. So in a normal Weber test, of course, it's going to be lateral. They can hear it in both. But if the sound is not lateral, and they hear stronger in one ear than the other, then that might be an indication of hearing loss. So that would be conductive hearing loss. So what I would say is, if the sound lateralizes or is heard better in the good ear, the ear without the hearing loss would be sensorineural hearing loss. Like I like to think of a good sense of that one when the sound is heard better in the good ear, is sensorineural hearing loss, and that's all you need to remember. So the good ear is sensorineural, the bad ear is conductive. Okay, let's move on. So here's just a closer look of the Rhine test, where you position the tuning fork. So you can see it behind the ear is touching the bone. And then when you move it middle to the front of the ear, it's like right in the ear canal where you can hear. That's the ear conduction. Okay. And then this is the Weber test, where you hit the tuning fork and you put it right on the top of the forehead and ask them, do they hear more in one ear or the other? What are some common ear conditions? Okay, so what would we suspect if we saw a red bulging tympanic membrane, or TM is what we abbreviate it for? What would we think if it's red and bulging? So a lot of times we relate red to inflammation. Inflammation, the medical term for inflammation is itis. So we're looking at the ear. What would you think? So if you're thinking otitis media, you're right. Now, how do we know that this acute otitis media, AOM, or if it's not acute otitis medium, but if it's otitis medium with an effusion, OME, what we would do is an otoscope examination. So upon examination, when you're using your otoscope, if the TM, the tympanic membrane, if it's acute otitis media, if it's bulging, effusion, you're going to see a yellow or clear fluid behind the ear or behind the tympanic membrane, and it's not bulging. So the bulging to me is like a key indicator when I'm looking in the ear if it's acute or not. And so why is this important to know? This is important to know is because in acute otitis media, we treat with the oral antibiotic, and with otitis media with an effusion, we treat the signs and symptoms like nasal steroids and something along that line. But who can tell me what's the first line of treatment for acute otitis media, if you know? And if you're thinking augmentin, that is true, or even a cephalosporin, that is also appropriate. Sometimes if we have patients with lots of allergies, doxy is also a good antibiotic. The preferred antibiotic drug for acute otitis media, it must be active against Staphylococcus pneumoniae, um, influenza, and cataralis. So you want to make sure it is an effective antibiotic that can fight those germs or those bugs in the ear. If it's acute otitis media with a fusion, that could persist that goes on for more than 12 weeks. So that's about 3 months or so. If they're still complaining, then we want to refer that patient out to ENT before we end up with further damage to the ear. All right. So what if what if the pain was on the outer ear and it hurts to move the pinna right along here, the pinna? What would that diagnosis be? That would be otitis externa. So, which is also called swimmer's ear. So you see this a lot of times with patients who swim a lot. And this is caused by a microorganism that's called Pseudomonas and sometimes Staph aureus. So if you remember how to treat otitis externa, is mild. If it's mild or moderate, you can actually use a topical treatment. But let's say if it's more severe and you notice a rupture, then you want to refer to ENT. And you can also get a culture of that drainage that's coming out the ear. And when you do that, you can match it up, match the bug drug. That's what we do, so we can select the right antibiotic drug to treat whatever that bacterial bug is in that ear. So patients will have a painful, inflamed, erythematous ear canal. The ear canal could be partially occluded with debris, but the tympanic membrane would be fine. It would look normal. If the tympanic membrane, if you can't visualize it or see it due to all the inflammation or the buildup that's in the ear, recommendation is that you would kind of drain the ear, clean it out so you can get a good look at the tympanic membrane. And it's also helpful with the healing process to get that ear canal cleaned out. But if it's not improving after 7 days or even after 14-day treatment, then you want to follow the current guidelines of what to do next for this problem. Okay, let's talk about this patient, 58-year-old male, left-sided hearing loss, vertigo for the last 3 to 4 days. So we have an Asian male who comes in saying his left-sided ears, he has hearing loss, vertigo. What might you suspect is going on with him? It would be acoustic neuroma, or sometimes called vestibular schwannoma. So let's point this out. You got to look at the demographics of the patient when you're looking at your exam. So in this particular case, acoustic neuromas are most common in the Asian population, with the patients between the ages of 50 to 60. And what we would do for these type of patients is beyond our scope of practice, unless you're actually working in with the neurologist, but you still will refer to neurology. This is often caused by a tumor on the acoustic nerve, so it's beyond our scope of practice. So we definitely want to refer out if we was to get this type of case coming into our clinics. Okay, vertigo. What is vertigo? If you haven't experienced vertigo, when a patient complains of vertigo, it can be very debilitating. It is like a sudden internal or external spinning sensation where it's often triggered by if you move in too quickly or swiftly, you can get vertigo. But most patients who have vertigo, they say they feel like they're floating or like the room is spinning. We have two types of vertigo, as you can see, peripheral and central. So peripheral vertigo, it refers to the disorders that are involved that involves disturbances in the inner ear, the vestibular neuritis, labyrinthitis, Meniere's disease, banal proximal positional vertigo, or we call it BPPV. That's the most common cause of dizziness or vertigo. So what maneuver can we use to diagnose the BPPV? First of all, we do a thorough history. If they say it's sudden, sudden hair movements, it lasts less than 60 seconds. It's quick onset, but it goes away. The causes often is like an ear infection, hair trauma, or it could be idiopathic. We don't know what causes it, why it's happening, and treatment just depends on the cause. Um, for BPPV, vestibular rehab or Epley's maneuver is helpful. Either have the patient do the exercise at home, or you can refer them to PT, physical therapy. And if the good thing about the internet now or YouTube, we have very good videos to give a good visual of how to do an Epley maneuver. So patients can do these things at home, move maneuvering to the right or same with the left side of the head. If someone has central vertigo, it's typically more serious and it's caused by something like we would consider like maybe trauma or a stroke, a trauma to the brain or trauma to the head rather, or a stroke. Meniere's disease is classic symptoms. It's episodic, vertigo, tinnitus, hearing loss. The duration is like dizziness, persists at least 20 minutes, but something more central, if it's a brain trauma or stroke, we need to know when to refer or recognize the difference between these symptoms and get them seen to by a neurologist. Okay, let's move a little further down to nose and throat. One of the most common complaints that you hear from patients is rhinitis, runny nose, a chronic rhinitis, like or allergic rhinitis. There's so many, it's different ways to diagnose. But how do we treat rhinitis? If it's allergic rhinitis, the first line is to remove any allergens. What's causing the nose to run? What are you around? What are the aggravating symptoms? That's where that old cart really comes into handy, where you can kind of identify what is happening or what they're exposed to that's causing this allergen or allergy attack. So most people's allergic rhinitis is related to something environmental, so something that they're exposed to or something they're around. And we also would treat them with a topical nasal spray like Flonase. These are not even prescriptions anymore. You can buy them over the counter, or fluticasone. Some patients, I take that back. Some patients who have certain type of insurance and they cannot afford to just go and buy nasal sprays, it can be very pricey. They can, if they can't afford to buy them over the counter, you can write a prescription for fluticasone and possibly have the insurance pay for it. Just all depends on their insurance. So if that doesn't work, we can move towards some oral medications, which is still over the counter, decongestants like pseudoephedrine, oral antihistamine, cytarabine, which is Zyrtec, loratadine, which is Claritin. Sometimes some patients like to use Benadryl, but Benadryl is not a long-acting antihistamine that you want to take over time. Like you could take cytarabine or Claritin for longer periods. And then moving on. So when you're dealing with allergic rhinitis, the main thing you can do is treat the symptoms or try to get ahead of it. Let's say if someone has seasonal allergies, you can educate your patients to start taking their antihistamines a month or so before the seasonal allergies, the season hit before to prevent their allergies from flaring up. And also, you can take antihistamine like cetirizine or Zyrtec or Claritin all year round. And I often tell my patients kind of switch it up after 6 months if your body's getting used to it. And some people need to take medication all year round because they have allergies to every season. So it's just important to know that it is allergic and you don't need to treat them for a bacterial infection. Now, if they come in and they've had this runny nose for a couple weeks and now they have facial pain, purulent nasal drainage, they recently just got over a virus or something, and it's greater than 10 days, it may have went from allergic to probably viral, which eventually could lead to bacterial rhinosinusitis when they palpate on the face right here. This requires an antibiotic, which could be augmentin or something on that nature. Just remember, what's best. The treatment with amoxicillin for sinusitis. You can move to cephalosporin if they have penicillin allergies, but we want to try to treat them with beta-lactam because this medication penetrates the bony sinuses better. And patients will come in after having symptoms 3 days, the first onset, and they want you to put them on a Z-Pack. They want you to give them something because they know it's going to turn into a bacterial infection. And we just have to educate our patients and explain why we cannot just prescribe antibiotics like that, or we can't even give you antibiotic just in case it happens. We're just trying to get out of that habit of writing so many antibiotics when it's not necessary. Okay, epistaxis, nosebleeds. So here's a picture that you definitely have to have seen before. When people have nosebleeds, you probably had your own nosebleeds. This occurs most commonly in the anterior portion of the nose. That is called the Kesselbach's plexus, and it's very common among children ages 2 to 10. We would advise, what would we advise these patients to do? Well, of course, we apply pressure, some ice, lean forward. Leaning backwards can lead to swallowing blood, which causes a host of other issues. Some people get nauseated, they want to vomit, they can't stand the taste of it or things like that. So we just kind of tell them to lean forward and pinch their nose. A posterior nosebleed is a whole different ball game when it's posterior. It might indicate that there's a hemorrhage, which causes severe bleeding, and it's most common in people ages greater than 40. A patient is on anticoagulants, so it's very important to refer these patients to the ED where they can get proper treatment. Frequent nosebleeds, you want to refer to ENT or ENT to identify the source of what's causing the bleeding. Okay, let's move on. A deviated septum. Okay, so let's talk about a deviated septum. The most common disorder you will come across is a deviated septum. They are benign, which means they're harmless, but once in a while they may affect the way a patient breathes or even the way they sleep, and they may require some type of surgical procedure to correct it. But what if the deviated septum is perforated, like say a hole in it? This is how you would test for it. We use a translumination and shine a light on one side of the nose, and it shines right through to the other side due to the hole, which is caused by some type of birth defect or trauma or even drug use like cocaine. So we want to, so for a patient like that, we will want to refer. Let's keep moving. I know I got to get done. Mouth conditions. Your patient is in, and this is what their tongue looks like. So what's going on here? The first one is what we call like a geographical tongue. This is also benign. They have a mild discomfort with it, but it's associated with psoriasis or even reactive arthritis. Now, if a patient comes in with white patches that don't wipe off, um, that could be leukoplakia, which is a sign of oral cancer, very serious. My uncle actually was diagnosed with that when he went for a regular dental appointment. His dentist noticed this, and he had oral cancer. So it's very serious. So if you notice it, you won't refer them to their dentist. You just refer them out to oncologists for exam to be re-examined or reconfirmed. But to try to get them to the dentist and then the dentist confirm it's oral cancer, if you can identify that's what you believe it is, then I would just refer them straight to oncology. But if a patient says patches, they don't wipe off, they was recently prescribed an inhaled corticosteroid, what would you think is going on? Think about steroids, and we tell people when they're using inhalers, we tell them to rinse their mouth for a reason, and that is because a yeast could develop. So with the yeast that's developed on the tongue, we want to prescribe them a switch and swallow, which is nystatin, and for the treatment. If we see someone with a patient with a painful round oral lesion like this canker, or it could be aphthous or stomitis. This will usually resolve on their own, and we can recommend that they do warm salt water, like switch and swallow, and kind of gargle with the warm salt water. They can be super painful and uncomfortable. Sometimes magic mouthwash, it helps with the pain because it has diphenhydramine and lidocaine in it. So it often kind of helps it not be so inflamed when it's when it's healing, when it's going through the healing process. But we also want to keep in mind for mouth sores and get a thorough sexual history, because we want to make sure they may not be having syphilis or some type of other sexually transmitted infection disease going on. Okay, so let's move on. What is the cause of painful fissures in the corners of the mouth? That is called angular chelosis, and it can be acute or chronic. It is a painful condition where the skin on the sides of the lips are cracked and a fissure forms. This can be sometimes caused by a yeast or even things like a B12, vitamin B12 deficiency. So we definitely want to be digging down to the root of it, getting a thorough history to see what is the cause of it, so we know how to best treat our patients and if we need to refer. If a patient comes in complaining of a super dry mouth, sometimes dry mouth or some dry eye issues, like for over 3 months, it might be something called Surgeon's syndrome. And what we would do for that, that is like, what that really is an autoimmune disease, like let's say like a rheumatoid arthritis or lupus. Those are autoimmune. That's what the Surgeon's syndrome is. We would treat this symptomatically, like with eye drops, and sometimes even sour candies that can help produce the salivation in the mouth. So it's not really a treatment for cure. We just treat the symptoms. Okay. So moving on down to the throat. What causes these little white pockets that's happening that you see in the back of the throat? What would be the hallmark of identifying strep? Besides the sore throat, the stomach ache, and headache, other things that go along with strep is palatine petechiae. And that's those little blood vessels on the palate. They are all broken and very red. Additionally, we may have some anterior cervical chain adenopathy when you check down cervical chain. So this is definitely something you want to treat, and we'll usually treat it with a penicillin unless they have an allergy. And then we'll go with something like azithromycin. But what happens if you don't treat strep, or if it goes undiagnosed for too long? Someone can develop rheumatic fever, which can impact the heart and also kidney inflammation. So it's very important that you diagnose this correctly and get them treated. It's a in clinic we usually do the rapid strep test. Peritonsillar abscess. If you're looking at a patient's throat and the uvula is displaced to one side, and like we call it like a hot potato, a look that and they have sometimes a hard time when they're talking, they can feel it. The red flags, those are some of the red flags when they sound like their mouth is full. This is peritonsillar abscess. And it's also an emergency, so you want to refer them over to the emergency department. And 9 times out of 10, they'll probably end up getting their tonsils taken out. Mono, what causes mono? If they come in with signs and symptoms and you take a strep test and it's negative, but the patient has a sore throat, in this case, and they have posterior cervical lymphadenopathy and severe fatigue, that's a sign, or nocturnal fever, loss of appetite, weight loss, we definitely want to think mono, which is caused by the Epstein-Barr virus. And you don't give them antibiotics for this. It has to run its course. So because if you do give them an antibiotic, it may cause a rash. So with mono, we treat symptomatically, we treat the symptoms. And then we also want to check their liver and their spleen, because those are two organs that could be affected by mono. And so always monitor them for hepatosplenomegaly. And then when you diagnose someone with mono, you want to document whether they, you want to document no hepatosplenomegaly noted, or if it is, then you say that it is. Be sure that they are avoiding contact sports and for at least 4 to 6 weeks, because we don't want them to get injured or rupture the spleen or splenomegaly. If that happens, that would be very serious. So we want them to make sure they don't do any contact sports. With mono, you want to check their CBCs to see if it's elevated. This would, and then you also want to check for lymphocytes. Something else you want to monitor is to be sure that if their levels are elevated, you want to recheck them to make sure they're normalizing. You may also see elevated LFTs or liver function tests. It might be elevated for a while they have mono. The type of test we do is a mono spot or antibody testing. The complications of it, like I said, it's a ruptured spleen. And so educate the patient that mono is spread through saliva. We call it the kissing virus or kissing disease. So we want to make sure they're not kissing anyone or sharing any food or drinks or utensils. Okay, so I have a quick question. We have a patient with retinal detachment that requires an urgent referral. Permanent and severe vision loss can occur if the patient is left untreated. Healthcare providers must recognize and act. Knowledge of risk factors are crucial. Which factors place a patient at risk for retinal detachment? We'll just move a little faster. So here are the answers. The correct answer is A, increased age. And then we have a rationale of why it is A, and then B, C, and D. The choices are correct for family history, retinal detachment, cataract surgery, and myopia. So A is incorrect, B, C, and D are correct. Sorry, I said that backwards. And so A is incorrect. The age is not a risk factor for retinal detachment, because not for younger. And it's also good if you join Archer Review for our question bank, because you'll get all these types of questions and you'll get rationales of why the answer is correct and why the other one is not. So I want to recommend that really quick. So question 2, a practitioner wants to assess a patient's hearing after reports that the patient feels that they are constantly asking people to repeat themselves. The practitioner strikes a tuning fork and places on the base of the mastoid bone just behind the patient's ear and asks the patient to tell the practitioner when they no longer hear the sound of the tuning fork. The practitioner then places a tuning fork next to the ear and asks the patient if they can hear any sound. What does this test assess? Conductive hearing loss, sensorineural hearing loss, mixed hearing, or functional hearing loss? A, B, C, or D? A is correct. The practitioner is just formed the Rhine test. Okay, let's move on to the next question. Oh, that's it. Okay, I'm sorry. That is the end of it. And if you have any questions, I don't know if you have anything in the chat. I just want to put this screen up so you can just be here. We have a live online three-day review coming up in July. I really want to highly recommend that you take this review. We've been getting responses back from previous students who have taken archery review and have taken their boards and successfully passed. So we've been getting these success stories, which is awesome. And it's very affordable. $50 includes all 3 days, and even after review, you have 30-day access to the recordings, and it's very helpful. Don't forget, I mentioned the question bank. You can get that for 30 days, a free trial. When I was going through my studying for my state exam, my board exam, I did 100 questions a day for 30 days because they recommended that, and for great practice. So you get 30 days to have access to our question bank if you do the free version, and you can do 100 questions a day just to get used to taking the test. But we have over 1,500 questions, so I think it would be very useful. Please scan the QR code. Visit our Archery Review website for more information. If you you can find us on Facebook and other virtual platforms, read other customer reviews. I hope that you take advantage of this opportunity. It's very affordable, and some of them are free, so like our webinars. And thank you for your time. If you have any questions, can you access this recording again? The webinars. Rachel, are you able to chime in? I'm not sure. So what I can say, we do these webinars, at least 2 webinars a week. So I'm thinking between at least 8 webinars a month or so. You can always check the website to see what's coming up next. We do repeat these webinars. And and we do have personal tutoring. So for the person who asks, can you access the recording again? If you want to go over a certain system at any time, you can sign up for a personal one-on-one tutoring. Gabriella, let's see. You have a question? Y'all did good with the answers. All right, so if there are any other questions on here, I don't see them. Let's see. So I hope I answered your questions as far as getting a repeat of this session and taking advantage of our one-on-one tutoring. And if that's it, you all can reach out to us at any time on our website. And thank you so much for your time. Bye-bye.